One, we are live. Please start.
Okay. Namaste and good evening, everyone. I welcome you all for today's webinar on newer update on lung cancer treatment 2024. With immense pleasure, I would like to invite Dr. Manish Sharma. He is a consultant and head of unit medical oncology in Positron Super Specialist and Cancer Hospital, Rohtak, for the welcome and introductory note. The stage is all yours.
Thank you so much and good evening all. I welcome you all on this Wednesday evening, and today we will be discussing about the newer updates on lung cancer treatment 2024. And as we know that the lung cancer is the most common cancer, and I think the greatest achievements which have been made, they are in lung cancer. And for presenting different topics on lung cancer, we have different eminent speakers with us. And for the first session, I would like to invite Dr. Praveen Jain. He is consultant and head in Akash Healthcare Institute. He will be speaking upon the optimizing the treatment in lung cancer. Dr. Praveen Jain, good evening. Welcome.
Good evening. Thank you, Dr. Manish, for giving me this opportunity, and thanks for the warm welcome. So let me share my screen. So I think organizers, you need to stop sharing so that I can start sharing.
You can share it now.
Yes, I'm able to share now. So I hope my screen is visible and I'm audible too.
Yes, sir.
So good evening, everyone. So today I'll be discussing on optimizing the treatments in advanced EGFR mutated non-small cell lung cancer. So we've been talking about EGFR TKIs now and then since last so many years. So every time we talk about EGFR mutation positive non-small cell lung cancer, we have something new. So this time I'll be speaking on osimertinib only, but I'll just be presenting few more datas. So where sequencing it really doesn't help. So you have to use your best weapon in the first line. I'm going to present the some of the data pertaining to that only. So to set the ball rolling, EGFR mutation positive non-small cell lung cancer. So it is a common entity. If we look at the literature, almost 20 to 40% of non-small cell lung cancers they have EGFR mutation. So the EGFR mutation rate is higher in Asian population as compared to non-Asian population. And if we look particularly at Indian data, so the rates vary between 20 to 23% at some center and 30% to 35% at some centers. EGFR mutations, so they are located in the tyrosine kinase domain, and ultimately they results in increased kinase activity of EGFR, leading to continuous cell proliferation. So looking at the type of EGFR mutation, so we have four EGFR exons, so where the mutation can lead to non-development of non-small cell lung cancer. And recently exon 12 insertion, they have also come into picture. So almost more than 50% of these EGFR mutation, they happen to have in exon 19. Then the second most common is exon 21, out of which L858R is the most common one. Then exon 20 insertion, which was initially supposed to be a resistant mutation, and it was very difficult to target this. But now with availability of amivantamab, so we are able to target exon 20 insertion also. And the minority of them are exon 18 and exon 12. So this is a animation or diagrammatic representation of EGFR receptor. So this gray one is the wild type receptor. So this is the intrinsic mutant EGFR. So and this is the HER2 receptor, and this is the T790M positive receptor. So it's a acquired mutation which occurs after a EGFR TKI, where the patient has been exposed to EGFR TKI, and almost 50% of these patients, when exposed to first or second generation TKI, so they develop T790M. So we do have three generations of EGFR TKIs. The first generation TKIs are erlotinib and gefitinib. They bind with the EGFR tyrosine kinase in a reversible manner, and they have affinity towards the wild type also, and the mutant EGFR also. And they are not quite active on, and they are at least they are not at all active on T790M mutations. So looking at the second generation TKI, we have two available in market. So one is afatinib and the other one is the dacomitinib. So again, these second generation TKI, they irreversibly covalently binds to EGFR, HER2 and HER4 to inhibit the pan EGFR family signaling, and they have broader activity. So they also have lot of wild type EGFR activity, because of which they have more toxicity pertaining to this wild type blockade in form of rashes and in form of diarrhea. So coming to the third generation TKI, which is osimertinib. So it's a EGFR mutant specific inhibitor. So that means that it doesn't, just give me a second. So the third generation TKI, Pooja, the third generation TKI, which is EGFR mutant specific inhibitor. So that means it doesn't have lot of activity on the wild type. It predominantly acts on the EGFR mutant tyrosine kinase. So it binds irreversibly to mutant EGFR, and because of its mutant specific activity, it doesn't have the side effect pertaining to the wild type blockage. So that means it has a lot less diarrhea and rashes as compared to first or second generation TKI. So osimertinib, which is a third generation TKI, so it got approved on the basis of FLORA trial in the first line. So which was a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI, which at that point of time when this trial was started were the first generation TKI, and it was tried in locally advanced or metastatic EGFR mutated non-small cell lung cancer. So this we have already talked about the first, second, and third generation TKI, and they're like first one is the reversible, second and third generation are irreversible. So third generation they are mutant specific, second generation block wild type and mutant both. So one thing which is very important is the ability to cross blood-brain barrier. So the first and second generation TKI, they have minimal ability to cross the blood-brain barrier, and we already know that these EGFR mutated non-small cell lung cancer, they are very notorious. They go early in the brain, and almost 50 to 60% of these patients they have brain metastasis in the natural course of disease at some point in time. So looking at these receptor again, so this is again the pictorial diagram which is showing. So this is the EGFR mutation. So this is a wild type EGFR and this is a T790M. So the first generation, it is active against the wild type and the EGFR, primary EGFR mutated tyrosine kinase. Osimertinib or the third generation, these are active against the first two. So EGFR mutation primary one and the secondary one, they are not active against the wild type EGFR. So this is the study schema of FLORA trial. So they included those patients with locally advanced who were unresectable or metastatic non-small cell lung cancer who had EGFR common mutation. Common mutation were defined as EGFR del 19, deletion 19, or L858R, which was the exon 21 mutation, and they should not have received any prior EGFR TKI therapy. And those patients who had CNS metastasis, those who either were treated or those who had stable CNS metastasis, they were included in the this clinical trial. And the patients were randomized into 1:1 fashion to osimertinib versus EGFR TKI of standard of care. The primary endpoint of this trial was progression-free survival according to the RECIST 1.1, and there were a lot of key secondary endpoints: objective response rate, overall survival, patient-reported outcomes, safety, depth of response, disease control rate. One thing which is very peculiar, which we should definitely take a look at, so that those patients who were in standard of care arm, so they were allowed to receive osimertinib at time of progression, which we call crossover, and crossover was allowed in this trial in the SOC arm. So this was the primary progression-free survival analysis, which was published in 2018. And we can see that the median PFS with osimertinib was 18.9 months as compared to 10.2 months with EGFR TKI of physician's choice. And the hazard ratio was 0.46. We can see the graph separated at 1 month only. And after that, the graph remained separated. And in fact, the width between the gap between the graphs, so that kept on increasing with increasing time. So these were the subset analysis, and we can see that almost all the subset, they had consistent benefit with osimertinib. So however, there were few subgroups where the quantum of benefit with osimertinib was lesser as compared to the counterpart. So one group was L858R mutation, where it was slightly on the lesser side. The second one was the Asian versus non-Asian, where Asian patient, they did not get that much of amount of benefit as compared to non-Asian. But again, looking at the significant nature of it, so all the subgroup, they had a hazard ratio of less than 0.5. So which shows that the benefit of osimertinib was consistently present in all the subgroups. So this was the final overall survival, which was presented by Ramalingam, and which was published in NEJM in 2020. We can see that the osimertinib had a median overall survival of 36 months, and the comparator EGFR TKI of 31.8 months. And again, it was statistically significant and clinically meaningful improvement was seen. And this was in fact, if we look at the different time points, so at 3 years, 54% of the patients, so they were alive who were started on osimertinib, as compared to 44% who were started on the first generation TKI. So looking at those patients who were still managing well at 36 months on osimertinib versus first generation TKI, so 28% of the patients who were started on osimertinib, so they were continuing osimertinib at 3 years. And if we look at the first generation TKI, only 9% of the patients, they were continuing EGFR TKI at 3 years. Time to first subsequent treatment. So it's a newer endpoint which is considered as a surrogate for PFS and overall survival, and it is a complementary endpoint which suggests that the data is more strong if the time to first subsequent treatment is also significantly improved along with PFS and overall survival. So looking at time to first subsequent treatment with osimertinib, it was 25.5 months, and if we look at the comparator EGFR TKI, so it was 13.7 months. So there was almost doubling of time to first subsequent therapy or death. So this was the final PFS and OS analysis, subgroup analysis. So again, PFS, we already discussed that there was a consistent benefit as far as progression-free survival is concerned. with few of the subgroup which had slightly less amount of benefit as compared to the counterpart. Looking at the overall survival analysis, so consistently the benefit was seen with osimertinib. Again, two subset, one is the Asian population and one is L858R, where the quantum of benefit was less with osimertinib. So now coming to the biggest question. So there are two strategies. So one strategy is to use the osimertinib in the first line, and the second strategy is to start with first line or first generation or second generation TKI, and later on, if the patient progresses and has T790M, so then we expose the patient to osimertinib. So because with that, a patient can save lot of cost. So but does saving this much of cost, is it justifiable? So let us deep dive into this issue and let us see. So this graphical representation shows that out of 10 EGFR mutation positive patient who starts first generation TKI, only 3 they will be eligible to receive second line osimertinib. And how it happens? So we can just see over here that out of these 10 people, so let us take this thing. So like out of 10 EGFR mutated patients who are started on first or second generation TKI, so 73 to 77% of the people, so they will be eligible for second line therapy. So that means out of 10, 3 there will be attrition, maybe because of the death of the patient, maybe because of poor performance status, maybe because of non-availability of drug, maybe because of non-availability of test. So there can be so many reasons for that. So this out of these 7 people, so who are eligible for second line therapy, so only 60 to 76% of the patient they can receive a valid T790M test result, and this is because either they do not have a tissue biopsy on which the test can be performed, or a plasma test has been taken and but that doesn't show any cell-free DNA, or the cell-free DNA doesn't show T790M positivity, but there is a 20% chance that plasma test which is being negative might be a false negative, and the patient might be a T790M positive status. So this is a problem with T790M test result. And so in total, out of 10 people who started on first generation TKI or second generation TKI, only 5 people they had a valid T790M result. And out of these 5 patients, only 50% they will have T790M positivity. So that will be only 3 of 10. So they will be eligible for osimertinib in second line. So it's a bigger issue. So because we are denying the benefit of osimertinib to these 7% people, or to 70% of the people when we are using it as a sequencing approach. So the data for T790M results. So this shows that almost 60 to 79% of the patient they can receive an accurate T790M result. So rest of the people they do not have an accurate T790M results. So because of which they are not eligible for second line osimertinib. And there are few of the studies, so like Akamatsu, they observed that 79.2% of the patient screened for the AURA3 trial, they had a valid COBAS EGFR mutation test result, and 21% of the patient they did not had the valid results. So in 2014, Choad C et al. They said that they observed that rebiopsy was not possible in 20% of the patient, and if it was performed, so 25.6% of the patient they did not provide adequate tumor cells so that the testing can be done on that. So 60% of free biopsy specimen they were suitable for molecular analysis and 40% were unsuitable. So this was observed by Yoon et al. In 2012. And those patients who were given the option of rebiopsy, only 69% of the patient who gave consent to the biopsy, so they were tested for T790M. So there are a lot of limitation in testing for T790M, maybe because of the unavailability of biopsy, maybe because of the well, so these are issues which we always look for in our clinical practice. So looking at a very pertinent, another pertinent question. So how many patients, so they receive second line therapy and how many they discontinue therapy after first line? So looking at the experimental arm, that means the osimertinib arm. So 100% they were started on osimertinib. So 22% they are still on treatment. Out of these 78%, so 31% of the patient they did not receive any subsequent therapy. So this is an important thing. So which we were commenting on in the previous pictures, that 30% of the patient they do not receive the second line treatment. Out of those 48% who receive subsequent therapies, so 68% received cytotoxic chemotherapy and 29% received EGFR TKI other than osimertinib. So looking at the standard of care arm, again 100% started on first line EGFR TKI, 5% they are still on treatment. Out of 95%, 30% they did not receive any second line treatment. So again 30% is a number, so where the patient do not take or are not eligible for the subsequent therapies. Out of 65% who had subsequent therapies, almost half of these patients they received osimertinib as a subsequent therapy. So there was an absolute crossover rate of 31% patient in standard of care arm who took osimertinib as a second line therapy. So despite having 31% of crossover, so this trial showed a significant overall survival advantage. So which is a very promising result which has been shown by FLORA trial. So again, looking at the data in PAN phase 3 trials, so approximately one third of the patient they do not receive a second line therapy in phase 3 trial. So which is almost similar to the FLORA analysis. So where 30% to 31% of the patient they did not receive a second line therapy. So in fact, in a real world study of patients with EGFR mutated non-small cell lung cancer, the risk of not receiving second line therapy is quite high. So 130 of 140 patients who were exposed to EGFR TKI, 112 patients, they were candidate for second line therapy. And out of these 112 patients, 34 patients, they did not receive any second line therapy. And the reason why they did not receive second line therapy was patient refusal into the poor performance status, and probably and most frequently it is due to CNS metastasis, was in 26 patients, and there was a rapid progression and death in 6 patients. So this is very important that 30% of the patient when exposed to first line TKI, so they do not receive second line therapy. And in fact, if you see various global studies also, so looking at the US data, the Flatitron Health Electronic Health Record Database, then ASCO Cancer Link Database, USON database, then Market Scan databases. So you can see that only 9%, 7%, 16%, 17% patient they received second line therapy. And this is not only true in USA. So in Europe, in Germany, Japan, Singapore. So you can see that the data is consistent that 23% or 25% of the patient they receive second line therapy, second line osimertinib. It's not second line therapy; it is second line osimertinib when the patient had received first generation or second generation TKI. So in our pictorial diagram, we told that 30% or 3 out of 10 patients will receive second line osimertinib, and the same is the real world study across the globe. In fact, if we look at the Archer 1050 analysis, so we can see over here that out of 100 people, 100% of the patient who were initially exposed to first line EGFR TKI, so the no second line was received in 50%, and only 10% of the patient they received osimertinib as a subsequent therapy. So in the gefitinib arm, so 11% received the osimertinib as a subsequent therapy. So this is quite less, and I am telling you the real world situation is similar, and this is predominantly because of the testing, because of the poor performance status which the patient gets, and sometimes the patient is not able to afford the second line treatment, and probably all these contributed to such a low adoption of osimertinib as a second line. So now coming to the final slide. So two strategies. So osimertinib first or a sequencing strategy. So in osimertinib first, we are giving the benefit of osimertinib to almost all the patients with a median PFS of 18.9 months with osimertinib and with a median PFS of 6 to 7 months with the chemotherapy and the overall survival of 36 months. In a standard of care arm, 10.2 months with EGFR TKI, then second line osimertinib in only 30% of the patients, followed by chemotherapy. So one third of the patient they will get benefit of osimertinib similar to what osimertinib in first line is doing, but two-thirds of the patient they will not get the benefit of osimertinib, and their median overall survival is going to be pretty low. So the key messages with this presentation is that osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. So it was the first to demonstrate overall survival advantage in EGFR TKI group. Then osimertinib improve overall survival versus first generation TKI in untreated EGFR mutated non-small cell and also T790M positive non-small cell lung as per the AURA trial. Then osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy. So it is well tolerated at 80 milligram per day. So AEs leading to dose reduction are frequent in the second generation, and it is very less with the osimertinib. And sequencing cannot be considered as the best strategy, as almost 70% of the patient they are not eligible to receive osimertinib in the second line. So NCCN guideline also recommend osimertinib as a category 1 option, which is a preferred option, and a rest of other TKI. So they are also category 1, but they are other recommended options. So with this, I would like to end my presentation. Thank you for patient listening. If there are any questions, I think we are good to go. Thank you.
Thank you, Dr. Praveen, for that lucid presentation. I think going with osimertinib in the first line is the treatment option, which you correctly said. And many of the patients, they will not be able to receive osimertinib in second line. So what do you see about chemotherapy combination in combination with osimertinib? So there is a first line data about that.
See, yes, the progression-free survival advantage is seen with the FLAURA2. So, but even the PFS analysis, so that is still not mature. I think we have to wait for that data. So, but yes, probably those patients where the burden of disease is quite high, or a poorly differentiated kind of situation. So there will be few situations so where you might go ahead with osimertinib along with chemotherapy. So I had one patient with uncommon mutation S768I. So there I had two options. So one was afatinib and the second was osimertinib. So the patient had taken afatinib for 10 days to 12 days, and the patient had grade 3, grade 4 diarrhea. So the patient was not able to continue with afatinib. So at that point of time, I had the option of osimertinib. So I know I should not do that, but I extrapolated the data from FLAURA2 because this is one subset where the TKI responses are close to 40 to 50%. So I do not want to miss the opportunity of giving chemotherapy also. I counseled the patient for osimertinib along with chemotherapy. The patient agreed. I started the patient on osimertinib plus chemotherapy, and the patient has been doing fine. So it's been, I think, 10 to 12 months approximately, and the patient is doing fine with osimertinib plus chemotherapy.
And how did you find the side effect of the combination? It was tolerable.
So the there was another patient of EGFR mutated non-small cell lung cancer where I started osimertinib plus chemotherapy. So both the patients, so they've been doing fine. So there were no safety issues, no challenges which were seen by me during the treatment.
And thank you, Dr. Praveen, for such a lucid presentation. Thank you so much.
Sir, I also have one question.
Okay, Dr.
Hi,
Abhishek.
Abhishek.
please.
Hi, sir. I also have one question, sir. Any experience about using this combination, erlotinib plus ramucirumab?
नहीं यार. So erlotinib plus see the point is denying the benefit of osimertinib. So it is only for the sake of affordability, nothing else. See, it is better
नहीं,
tolerated as compared to.
Cyremza 2 is not very affordable, but they are
नहीं
claiming
वही
a
मैं
very
बोल
good
रहा हूँ
PFS of.
osimertinib नहीं but osimertinib को see there is a subset analysis ki L858R it does better as compared to osimertinib. So but that is a subset analysis, and that too that is not all that is also not a pre-specified subgroup analysis, and that too in a overall survival, so which is a secondary endpoint of the trial. So overall survival was not the primary endpoint of the trial. The primary endpoint was progression free survival, and if you look at the subset analysis of L858R versus DEL19, the hazard ratio with L858R was also 0.48. So I don't think so that we should try to use such an expensive drug just on the basis of one logic that it did not had a significant overall survival advantage in that subgroup, but it had a significant PFS advantage in L858R also. So other than that, the same thing is for Asian population also, where probably the erlotinib plus ramucirumab, so it is shown to be having a significantly better outcome as compared to the counterpart. So, but I think again the similar kind of explanation for that also. So here also in Asian population PFS analysis, the hazard ratio was less than 0.5, and overall survival it was not statistically significant.
And moreover, we don't have any head-to-head
So
trial.
I am not a very big fan of. So these are all cross-trial comparison, and apart from that, see, ramucirumab is a costly drug, and
Very costly drug.
a very costly drug. So the cost of ramucirumab that will be almost 2 times or 3 times that of this thing, and the patient has to come for injectable therapy. So if you
Yes,
want to
that
go
is.
ahead with the injectable therapy, I think FLAURA2 strategy is a better off strategy. And if the patient doesn't have finances, then gefitinib plus chemotherapy is also a very good strategy.
I just asked this question because somebody recently told me that somebody had put 2, 3 patients on this thing, the panel patients who had no problem in getting the drug, and the PFS is fantastic in both all 2, 3 of them. I recently got this information, so I thought I must ask you.
So the PFS is good. The PFS is also good with osimertinib.
Yeah,
Yes.
so this is
See,
something
I
which
think
I thought.
2, 3 patients. So we have a small experience. So we cannot extrapolate the data, and we cannot compare the phase 3 trial with our experiences.
Absolutely.
I think apart from this, Dr. Praveen, one thing must be kept in mind that osimertinib has a brain penetration as well, which
Yes.
is not present
So that is
with
another very important thing.
erlotinib with ramucirumab combination.
And as we saw in the Archer analysis also, so most of the progression, most of the patient who did not receive second line therapy. So that was because of these CNS progressions. So most of the patients, they had CNS progression, and they were not a candidate for subsequent therapy because of it.
So with this, I would like to thank Dr. Praveen, and our next speaker is Dr. Abhishek Yadav. He is a senior consultant and head at Yashoda Hospital, and he will be speaking on the molecular testing in lung cancer. Welcome, Dr. Abhishek.
Thank you, Dr. Manish. Thank you, organizers. I think this topic that we are going to discuss has already been discussed many times, but still, this makes quite an interesting topic to discuss. Uh, is my screen visible?
Yes, Dr.
Yes,
Abhishek.
sir.
Yes, sir.
Okay. So the topic that I'll be discussing today is molecular biomarker testing in lung cancer. The slide is not scrolling down. Can you please share the slides from my side?
Sure, sir.
Thank you. So we will discuss this topic under following headings: lung cancer in India, biomarker testing in NSCLC, evolution of biomarker test in NSCLC from past to the current scenario, and the key takeaways. Next slide. So this is the Globocon 2020 data, which shows the burden of lung cancer in India. We can see that lung cancer forms almost 72,510 number of new cases in both sexes in all ages. And in terms of males, it forms even a more significant percentage. That is 8% in the males, new cases, versus the 5.5% in both sexes. So this is one cancer which forms one of the major burdens of cancer patient in India. Next slide. So this forms the second most common cancer in males in India. Next slide. So 50% of patients with advanced non-squamous NSCLC have a driver mutation targetable with the FDA approved agent or on a clinical trial. So this mutation can be ALK, which can be targeted by the ALK inhibitors, first, second, or third generation. EGFR sensitizing mutations, again, targetable by so many EGFR, anti-EGFR TKIs. KRAS mutation, exon 20 insertions, MET exon 14 skipping mutations, HER2 new overexpression or mutation, ROS1 translocation, BRAF V600E mutation, RET fusion, or anti-RK fusion. So, but the driver mutation, the unknown oncogenic driver mutation detected in 31% patients, and the most common being the EGFR, followed by KRAS, the most common being the KRAS, and followed by EGFR, followed by ALK. Next slide. So the importance of biomarker testing in non-NSCLC studies have shown that patients with identified actionable mutations who receive appropriate targeted therapy have improved outcomes. So we can see that the blue curve shows the patients who have received a particular targeted therapy against the genetic mutation, and the red curve shows no targeted therapy. So we can see the separation of curves right from the early follow-up, and the survival benefit is maintained over the span of 50 months. Next slide. So almost all guidelines recommend routine biomarker testing to guide treatment decisions in advanced NSCLC. ASCO recommends the testing of EGFR, ALK, ROS, BRAF, MET, RET, NTRK, KRAS, and PDL1. NCCN also recommends testing of all of them. ESMO skips MET exon 14 skipping, RET fusion, and KRAS mutations. And CAP IACLC AMP skips BRAF, MET exon 14, RET, and NTRK fusions. So it all depends upon the local policy or the national policy or the cost constraints or the things guided by the insurance people. But we all know that it is important to test almost all patients with the best possible test that can routinely test the maximum number of biomarkers in a non-small cell lung cancer patient, especially when the patient is a non-smoker. Next slide. So there are various methods of tissue testing in NSCLC. They are DNA sequencing like NGS or PCR, then RNA sequencing, which detects fusion abnormalities, which are more sensitive for ALK, ROS, RET, and NTRK. Then IHC oblique FISH. So IHC and FISH both are good enough for ALK and ROS1. IHC detects ALK and ROS easily and fast, but not reliable or sensitive enough to guide treatment. Also detects PDL1 nicely. Next slide. So how did this biomarker testing in NSCLC evolve from past to the current scenario? Next slide. So the tissue can be a resection, it can be an excision biopsy or small tissue biopsies. So small tissue biopsies are the most common ones. Then an FFP block is made, histology, cytology, and then DNAs or RNA is extracted from that. It can also be a cell block from the tissue fluids or the urine, ascitic fluid, pleural fluid, sputum, CSF. Liquid biopsies are also possible, like from blood or from a cystic fluid. And if we talk about DNA, then the assessment methods are PCR, cancer gene panels, there are specific lung cancer mutation panels, the MSI testing, targeted mutations, RNA can be sequenced with RT-PCR, gene expression panels, and RNA sequencing. So proteins can be sequenced with, or proteins can be, analyzed with proteomics. Next slide. So the role of biopsy is to establish diagnosis, determine the histological subtype, and form the basis for the further biomarker testing. So histological subtyping can be a squamous or non-squamous subtype. For biomarker testing, primary tumors or metastatic lesions are equally suitable. Bone biopsy can be suboptimal due to decalcification. So the agents that we use for decalcify can lead to a bit of degradation of the DNA. Liquid biopsies or cell-free DNA in plasma are another option. So testing for EGFR, ALK, ROS, BRAF, V600E, and TRK, RET, MET exon 14 in all non-squamous NSCLCs are recommended. Use of broad NGS testing to detect most mutations using least amount of tissue is preferable. For squamous NSCLC, consider testing in young, never or light smokers, or if biopsy specimen is of mixed histology. Testing for PDL expression 1, PDL expression should be done in all NSCLC patients. So completion of testing within 10 to 14 working days of biopsy is recommended. I think this is what we are seeing these days. The TAT for almost all the lung cancer mutation panels and NGS have improved from past to present. Next slide. So circulating DNA testing has potential to be applied across all stages of NSCLC and throughout the treatment pathway. It not only helps in detecting, diagnosing, and treatment selection, it also helps in monitoring prognosis, response to treatment, and progression or relapse of disease. Circulating tumor DNA testing overcomes some major challenges associated with tissue testing. First, it is minimally invasive, allows for serial testing, And the circulating tumor DNA in the bloodstream is comprised of DNA from all tumor sources in the body and captures both tumor heterogeneity and tumor changes over time. So I think this is one major thing, that this DNA is sourced from all the sites, and it carries the history of the tumor changes that has occurred over the time, or the burden of mutations that the tumor has accumulated over the time. Circulating tumor DNA genotyping is recommended for clinical use in advanced NSCLC to guide treatment selection under specific circumstances. In resectable NSCLC, ctDNA testing is not a part of current clinical recommendations, but we don't know about the future. This might be applied in the setting in the future as well. So ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role in supportive treatment selection in patients with NSCLC. Next slide. So ctDNA may be used to detect minimal residual disease after surgery in resectable NSCLC, which can guide us which patients should be kept under close observation, who are a candidate for further treatment, So this is the TRACERx study, which included 24 early staged NSCLC patients followed longitudinally after resections. So phylogenetic ctDNA profiling was done. 93% of patients with disease recurrence were MRD positive, and 90% of patients without recurrence were MRD negative. So I think this is a very interesting study, though done in a very small number of patients. But this is something which can predict the patients who are likely to have a recurrence. So currently, MRD cannot be identified using traditional diagnostic methods. As detection of ctDNA in plasma indicates the presence of residual tumor tissue, it can be used to measure MRD. But additional studies to assess ctDNA for monitoring treatment response and relapse in early stage NSCLC are ongoing. Next slide. So if we compare the tissue versus liquid biopsy testing, there are similarities and differences. Sample acquisition is from blood in liquid biopsy, 10 ml whole blood. Tumor tissue is an invasive procedure. Repeat sampling can be bit challenging in tumor tissue because it is, after all, it is an invasive procedure. The lesion might be at such a place where the biopsy might be risky. So liquid biopsy is very easy to obtain. Biology correlation with histology and cellular subtype is possible. Direct correlations between ctDNA results with histology subtype are not possible. More reflective of tumor genomic landscape uh, rather than histology or cellular phenotype. Sensitivity of assay required, the lower tumor content acceptable with sensitive techniques. Very sensitive methods are required for ctDNA. Analytical standardization, the tissue biopsy is, over the time, it has been a valuable thing, a very validated procedure. ctDNA is something uh, which is an evolving science, and there are no strict guidelines which can quantify the performance characteristics of liquid biopsies. And again, the evidence of clinical utility, the tumor tissue or the solid biopsies are very well established. They have a substantial evidence in various studies and various trials. Liquid biopsy, the science is still evolving. The utility is not that much confirmed by the trials, but then the process is evolving, and I think it will be even better and better as the time passes. Next slide. Next slide. So multiple genes involved in NSCLC, single gene reflex testing, advantages of NGS over individual mutation testings. So as the number of clinically actionable biomarkers has increased, the ability to evaluate all known molecular alterations in a single test has given advantage to NGS. So at one go, we can test so many biomarkers. We don't need one testing. So it also saves the tissue, and so in some cases, it also saves the money. So next slide. Techniques and molecular landscape in NSCLC, there's single gen, we have already discussed this, single gene assays, Sanger's, allele-based PCRs, IHCs, gene panel assays, amplification, amplicon-based panels, hybrid capture sequencing, next generation sequencing, FISH. Next slide. So this tells about the frequency with which we encounter these target mutations. So EGFR forms 30 to 40%, KRAS forms 20 to 30%, MET forms 2 to 5%, ALK forms around 3 to 7%, BRAF again 0.5 to 5%, ROS 2 to 3%, RET 1 to 2%, NTRK 1 to 2%, and HER2/neu again 1 to 5%, which can be a mutation, insertion, amplification, or overexpression. There are some other small other biomarkers like P10, PDGFR, PIK3CA, TP53, B2 third, and CDKN2A, which happen in less than less than around 5% of the patients. So we will see further which molecular biomarker testing methods are preferred for these different mutations. Next slide. So now we see the EGFR mutation. Next slide. So samples are the fresh formalin fixed sections. Fresh sections, frozen or alcohol fixed specimens can also be used for PCR assays. Cytology samples are also suitable. Cell blocks are preferred over smears. Next slide. So when to do an EGFR mutation testing in early lung cancer? Next slide. So NCCN considers adding molecular testing for EGFR mutation on the diagnostic biopsy or the post-surgical resection sample to ensure that EGFR mutation results are available for adjuvant treatment decisions for patients with stage 1B to 3A NSCLC. For patients with EGFR mutation positive NSCLC who received previous adjuvant chemotherapy or are ineligible to receive platinum-based chemotherapy. Next slide. So consider adding molecular advantage of NGS over PCR. One study showed that 48.6% of EGFR 20 insertion mutations identified by NGS are missed by PCR. Out of 17 most common EGFR exon 20 insertion mutations, only 4 can be identified by PCR. So I think EGFR exon 20 insertion is something where NGS has a definite advantage over RT-PCR. Next slide. So we see the ALK rearrangements in NSCLC. Next slide. In most cases, ALK-IHC is 93 to 100% sensitive and specific compared to FISH. In so many years of practice, I have come across only one patient where the IHC by D5F3 was equivocal, and later on I had to get the patient tested by FISH, which showed that the patient doesn't have an ALK mutation. So it is quite a sensitive test with a very good correspondence between the ALK and the FISH. False positivity rate is only 0.51% with the FISH. IHC is less expensive and hence more widely adopted. Next slide. ROS1 rearrangement. Next slide. So this is the algorithm for predicting genetic testing in ROS1 testing in advanced NSCLC. So the routine practices, we get EGFR mutation testing done, KRAS plus minus KRAS by the PCR NGS. We get a ROS1 by IHC or ROS1 by FISH. If ROS1 is positive in IHC, we get it reconfirmed by a second method, that is FISH or some other molecular assay. If the ROS1 is positive by FISH, we may consider reconfirmation by a second method. But if ROS1 is positive by IHC, the FISH should be done and it should be reconfirmed by the FISH. Next slide. So this is the RAS pathway. The EGFR gets stimulated by its ligand. Then the RAS, RAF, MEK, and ERK get stimulated, and then finally cell proliferation and survival. So mutations in KRAS are mutually exclusive with EGFR and ALK mutations and accounts for nearly 30% of lung adenocarcinomas. The most common of these arise in codons 20 and 13, and with the G12C variant found in 13% of patients with lung adenocarcinoma. This is the most common variant, predicting a poor prognosis versus a wild type KRAS. So the method of detection is a single gene KRAS G12C testing is not currently recommended and should be performed as a part of multi-gene NGS panel only. So the targeted therapies, identification of targeted therapies for patients with KRAS mutations has been hindered by the protein's structural biology, which has no binding pockets large enough for the therapeutic agents. Sotorasib is currently approved for patients with NSCLC, and trials of adagrasib have showed potential in early phase 2 and 3 trials. Acquired resistance to therapy has been observed, although specific resistance mechanisms are not well understood. Next slide. So BRAF mutations, BRAF V600E mutation is the most common mutation. If there is a BRAF mutation, more than 50% harbor this V600E type and is thought to be more prevalent in smokers. Non-V600E mutations such as V600K, G466V, and G469A are less prevalent and occur in 17% of patients. Overall, we have already discussed BRAF mutations occur in 1 to 5% of patients. So method of detection, while not widely recommended, ISC and PCR are generally recommended methods for single gene BRAF testing. NGS is generally used for the multi-gene test panels. So the targeted therapy is the dabrafenib and trametinib combination. Resistance develops via the pathways that bypass RAF, such as redirection of cell signaling via the downstream MAC1 or 2 kinases. Next slide. So c-MET receptor tyrosine kinase and MET exon 14 skipping mutations in NSCLC. So in cancer, MET exon 14 skipping mutations cause in-frame deletion of juxtamembrane domain, resulting in increased stability and constitutive kinase activation, found in 3 to 4% of non-squamous NSCLCs and 20 to 30% of sarcomatoid cancer. So it is more common in the sarcomatoid subtype. Majority of MET exon 14 skipping mutations can be detected with DNA NGS, but increased sensitivity with RNA NGS. So RNA NGS is the preferred method for c-MET exon 14 skipping mutations. Next slide. So methods which are recommended for this testing, this mutation detection is IHC and FISH are not recommended. PCR is the preferred method. PCR can be done, which can be a DNA or PCR. RNA PCR has some technical considerations. NGS, the DNA NGS is acceptable method, but RNA NGS is most sensitive. Next slide. So RET, receptor tyrosine kinase and RET fusions, normal role in neural and genitourinary development, found in 1 to 2% of non-squamous NSCLCs, 10 to 20% of papillary thyroid carcinoma. So this is more common in thyroid carcinoma, but can be found in non-squamous NSCLCs in a very low percentage of patients. So I have a patient, a very young female, almost 32 years old, with this mutation. But the drug is not available in India, so right now undergoing chemotherapy only. So majority of RET fusions can be detected by DNA NGS, but with increased sensitivity with RNA NGS. So like RET, like MET, this the preferred method is RNA NGS with this mutation as well. Next slide. Majority of RET fusions can be detected by DNA NGS, but there is increased sensitivity with RNA NGS as we have already discussed. IHC and FISH both are not preferred. Next slide. So testing for anti-RK fusions, options are IHC, RNA or DNA NGS, FISH or RT-PCR. There are advantages and disadvantages with each of them. RNA NGS being the most sensitive one. IHC is widely available and has a faster test. That reflexing to NGS via IHC is reasonable for NSCLC due to low prevalence of anti-RK fusions. So because of low frequency of this mutation, the standard is go for an IHC. If it is positive or doubtful, then go for the reflex testing with NGS. Next slide. Next slide. So HER2 mutations in NSCLC. So present in 3 to 5% of NSCLC adenocarcinomas, mostly exon 20 in frame insertions, mutually exclusive with other mutations, mostly seen in never smokers, worse OS than other subtypes. In NSCLC, HER2 mutation and amplification must be identified using an NGS DNA panel, similar to breast cancer. So IHC is used to assess the overexpression seen in 59% of NSCLC cases. 2 to 3 positivity we see in up to 30% of patients. Next slide. So this is the 2022 treatment paradigm for molecular biomarker positive advanced NSCLC. The common ones are in terms of EGFR, the common ones are DEL19 and L858R. Osimertinib is preferred, followed by other EGFR TKIs. Uncommons are the exon 20 insertions, which can be targeted by amivantamab or mobocertinib. Again, furthermore, uncommon are like LS768I, L861Q, G719X, which can be targeted with afatinib or osimertinib. ALK, we have a lot of TKIs as well, alectinib, lorlatinib, brigatinib. ROS1 can be targeted with crizotinib or entrectinib. BRAF V600E can be targeted with dabrafenib trametinib combination. And TRKs by entrectinib or larotrectinib. RET can be targeted by selpercatinib or prasiltinib. MET exon 14 skipping mutations can be targeted by capmatinib or tipotinib. KRAS can be targeted by sotorasib. So follow treatment options for adenocarcinomas, squamous cell carcinoma without actionable biomarker. The chemotherapy or chemotherapy plus immunotherapy combinations can be tried. Next slide. So PD-L1 expression in NSCLC. Next slide. So the antibody clones are 22C3, SP263, SP142, 28-8. 22C3 is used by the platform of DACO and 28-8 is also used by DACO. SP263 and SP142, the platform used is Ventana. I think they are the sister tests. For pembrolizumab, it is recommended as 22C3. For nivolumab, if we are doing it on DACO, it is 28-8. And for atezolizumab, it is Ventana SP142, and for durvalumab, it is SP263. So this can be a companion or complementary testing. Scoring systems can be in terms of TPS or in terms of CPS. Next slide. Next slide. Next slide. So conclusion, biomarker testing in SCLC has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Sample should contain adequate tumor content, at least 10% to prevent delay in processing. Ideal time is 2 weeks, that is 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated TAT. Next slide. So this is a summary. What oncogenic targets and what are the testing methodologies for them. EGFRs, the preferred are PCR and NGS. BRAF, it is PCR, NGS, and IHC. KRAS, it is PCR and NGS. ALK, FISH, NGS, IHC. ROS1, FISH, NGS, IHC, RET, FISH, and NGS, MET exon 40 mutations, NGS, NTRK, FISH, NGS, MET amplifications, FISH and NGS, HER2 mutations, PCR and NGS, and tumor mutational burden, NGS. Next slide. So, broad molecular profiling is a key component of the improvement of care in patients with NSCLC. Next slide. Thank you so much for the patient listening. If
Thank
there are
you,
any
Dr. Abhishek.
questions, they're welcome.
Thank you, Dr. Abhishek, for that extensive presentation. If there are any questions, we can take few questions. So, if there are no questions, we will move to the next sessions. This is by Dr. Kapil. He is consultant and unit head at RGCI Niti Bagh, and he will be speaking on the exceptional response to EGFR TKI, that is osimertinib in NSCLC, metastatic NSCLC. Over to you, Dr. Kapil. Thank you, and I welcome you here.
Hello, good evening, everyone. Thank you, Dr. Manish sir, for inviting me to deliver this talk. I hope I'm audible and my slides are visible.
Yes, Dr. Kapil, yes.
Yeah. So I will be talking about some cases there we have seen the exceptional response to osimertinib, obviously in the metastatic EGFR metastatic NSCLC cases. So this is a case study in October 2020. So we have Mr. X, who is a 64-year-old gentleman who presented to us in OPD with complaints of cough, progressive breathlessness, and severe backache. He could not walk without support in the last 10 days, complaining of giddiness since 5 to 6 days, and weight loss of 5 kg in last 1 month, which is significant. He is a non-smoker. So PET scan was done. So it showed a mass lesion in left upper lobe of lung with hilar nodes. 4 centimeter was the size of the tumor and multiple bony metastasis, as you can see in this PET scan images. There are hilar lesion. So biopsy was done from the lung mass, which showed presence of adenocarcinoma. On IHC testing, it came out to be TTF1 positive and NAPSIN-A positive, and it was negative for P40. So it is confirmatory for adenocarcinoma. So prevalent at that time, we did a molecular analysis, which showed presence of EGFR exon 19 mutation. KRAS was wild, BRAF negative, MET exon 14 negative, ALK negative, ROS negative, and HER2 negative, and PD-L1 expression was also 0%. So we did an MRI scan also because he was complaining of giddiness, and also as per the metastatic NSCLC protocols, which showed multiple ring enhancing lesion in the cerebellum and cerebral hemisphere with significant perilesional vasogenic edema. As you can see in the MRI images also, there is a mass lesion. So we made a diagnosis of stage 4 NSCLC adenocarcinoma with exon 19 deletion, EGFR exon 19 deletion with bone and bony metastasis. So management of this case, obviously, patient was given local radiation therapy for metastasis, whole brain radiation therapy was given, and EGFR TKI had to be added. So osimertinib was given because we know by this data that initially the first line EGFR for EGFR mutated cases, the first line TKIs came out. They gave geftinib and erlotinib, given PFS of 9 months to 10 months. With the second generation afatinib and dacotinib, it raised slightly to 13 to 14 months, while the exceptional PFS has been demonstrated by osimertinib, which is now 19 months. So the dose of the osimertinib, we know we give 80 mg per day. So in the treatment, so we have to decide. So osimertinib was started, particularly in this degree of CNS penetration of osimertinib is shown as per the individual regional distribution. So there are 8 cases: subject 1, subject 2, subject 3, subject 4, 5, and 6. So higher the SUV, the red color, then more is the penetration. So if we look at the regional distribution and binding of osimertinib on PET parametric images, they are showing total volume of distribution, which is very high in PET3. The day 1, day 2, and day 22. We have patient 1 and patient 2 have 2 cases we have. So in the PET1, we hardly see any penetration of the osimertinib. By day 2, there are a few dots of red color dots which are showing presence of osimertinib tracer. And at the day 22, which is 3 weeks after osimertinib, we see plenty of the osimertinib penetration in the brain. While we see in the second case, we see in the by day 22, lots of osimertinib is present in the brain. So a patient who is on EGFR mutated NSCLC had CNS metastasis. So if patient is symptomatic, then of course we have to treat first with the local therapy by SRS or whole brain radiotherapy, or by surgery, stereotactic surgery also we can give. If patient is not symptomatic and brain metastasis are incidental finding, we then start on third generation TKI, that is osimertinib, and we need not go for local therapy in these patients. However, if patient progresses on this thing and brain lesion has also progressed, then first, of course, patient is symptomatic, we are going to go with the local therapy. If the patient is not symptomatic and plain CNS PD is there, then we have to rebiopsy and look for T790M mutation, which can very well be done with the help of liquid biopsy. If T790M mutation comes out to be positive, we switch to osimertinib. However, if the mutation does not come out, then if isolated brain metastasis PD, we go for local therapy like SRS and we continue the TKI. However, if patient is not symptomatic mutation positive, then we go with the T790M mutation positive. If T790M mutation comes out to be negative after the local therapy, we switch to chemotherapy. So if we look at the FLORA trial, which demonstrated the efficacy of osimertinib with the first-line metastatic setting, if we particularly look at the patient who had or who did not have brain metastasis, if we comparison, we see in both the arms. So on the left panel, we have patient who had treated or known CNS metastasis. On the right side, we have 440 patient data who did not have any CNS metastasis. So in both the lines, we see that the curve is separating nicely in the favor of osimertinib. However, the osimertinib had a median PFS of 15.2 months with metastasis patient, and for 19 months in patient who did not have CNS metastasis. So obviously PFS was better in patient without CNS metastasis. However, the quantum of benefit given by osimertinib was consistent in both the groups. So if we compare osimertinib with other second generation TKIs like afatinib and dacomitinib, which also are supposed to have brain penetration activity. If we look at the FLORA trial, so we included the baseline asymptomatic CNS metastasis. However, afatinib trial also included baseline asymptomatic metastasis, but in dacomitinib trial, that was Archer 1050 trial, the brain metastasis were excluded via mandated scan at entry. So that's why we do not have any data of CNS activity available for dacomitinib. However, for afatinib, the response was there. Median CNS PFS was 5.4 months versus 8.2 months. However, it was much more significant, that is 9.6 months versus 15.2 months in case of osimertinib. Hence, we can determine that osimertinib is more effective than afatinib for CNS diseases. So treatment given for metastasis, so because of this gentleman had bone metastasis, so we gave palliative radiation to spine for backache along with zolpidem. That was started. For brain metastasis, patient denied to take brain RT and wanted to see later. He was started on first line TKI, that is osimertinib 80 mg per day. So this is the follow-up PET scan which was done in March 21. So almost 4 months later. So RT upper lobe, right upper lobe lesion encasing the right upper lobe bronchus was seen. So initially the lesion which was almost 4.1 centimeter, which had reduced to 2.2 centimeter, and right hilar and paratracheal lymph nodes had also reduced from 24 mm to 6.6 mm. So very good partial response, we can say. So if we talk about effectiveness of TKIs in the brain metastasis, so here we have CNS ORR of osimertinib, that is 66% compared to only 43% with the first line TKIs. If we look at CNS disease control rate, that will almost 90%, which is very nice, and median CNS duration of response is not reached in the osimertinib trial. So going further in this case, the follow-up MRI brain was also done in February 21, that is 4 months after starting the first line osimertinib. We see that the complete resolution of brain metastasis on MRI brain. You have to remember the patient did not undergo any kind of palliative radiation to the brain and no additional intervention was needed. So this is a real-world evidence case report on osimertinib and brain metastasis NSCLC. A 53-year-old patient relapsed while being on chemotherapy for stage 3A. Subsequent scan revealed pretracheal nodal hypermetabolism, and on repeat brain MRI, she was found to have a multiple brain metastasis, including a 3.1 centimeter inferior vermian metastasis with surrounding edema. Osimertinib was started. Patient complained of ataxia worsened significantly in the following days and was scheduled for craniotomy and tumor resection in the following week. So here we say This is another case report which showed complete remission of multiple brain metastases in a patient who had EGFR mutated NSCLC with the first line osimertinib without radiation therapy. This is another case report which had shown the similar efficacy in the CNS metastasis. This was a phase 2 open label 3-arm prospective proof of concept pilot study in which 48 patients with metastatic EGFR mutated lung adenocarcinoma received osimertinib 80 mg daily. So arm A, which had treatment naive arm, or arm B, which had previously EGFR TKI generation received and then shifted to osimertinib after having T790M mutation positive. So we see the median PFS of 11.1 months. So osimertinib demonstrated a high efficacy on brain metastasis, and all the trial arms displayed a significant decrease in the number and diameter of target CNS lesions. So further follow-up scan, November 21 to April 22. So this is almost complete response had been achieved. So discussion, radiotherapy for brain is not needed. Still patient had complete resolution of brain metastasis, which is points towards the high penetration in the brain of osimertinib. Almost complete resolution of primary disease and nodes. No adverse event were reported in this patient. Patient remained progression-free even after 19 months of initiating. He is asymptomatic, fully active, goes for morning walks, yoga session, normal life. So excellent response to osimertinib. Are these tumor different? Because every oncologist in the country has had such patient who respond excellent with osimertinib. Are these tumor different from the garden variety? Are there some tumor marker which can predict such excellent responses, or do we have any biomarker that we can predict such excellent response? That is yet to be seen. Thank you so much. If there are any questions, it was just a small case that I wanted to highlight to demonstrate the exceptional response to osimertinib. Over to organizers.
Dr. Kapil, thank you so much for presenting such a wonderful case. And so you have been using osimertinib for, we have been using osimertinib for quite some time. Any unusual kind of side effect which you have seen, like in the real world study which we have seen, there are plenty of side effects such as pneumonitis or thromboembolism phenomena. So have you encountered embolism or in such patients? Dr. Kapil?
Yes.
Dr. Kapil?
Yes, sir. I'm audible.
Am I audible?
Yes, sir. Audible.
So I am asking, in the real world studies with osimertinib, we have found that there are plenty of the patients who have thromboembolism or pneumonitis as a side effect. So have you ever encountered any patient with thromboembolism or pneumonitis as a side effect for when you are treating with osimertinib? Or any particular
No, sir. So, in my experience, the thing that I have encountered actually the skin reaction. Lots of, sometimes not lot of, but most of the patient tolerated very well. But in whatever side effect that I have seen is mostly skin related to the skin reactions and rashes. And I have not encountered any patient of alcoholism so far.
So the real world data which was presented in the OCFECT study, the incidence of thromboembolism was around 8%. So I have also not encountered any thromboembolism.
Also, sir, because my experience is also limited so far, so that might be actually one of the limited sample size.
Thank you so much for your presentation. So next, I will be speaking on reimagining the metastasis in EGFR mutant NSCLC, and I will be sharing my screen. So the topic for discussion is reimagining the CNS mutation in EGFR mutant advanced lung cancer, how treatment compares. So coming on to the incidence, without any epidemiological data, I think any of the presentation is incomplete. And we will be briefly discussing about the incidence of NSCLC. And Of all the cancers, the lung cancer is most common cancer worldwide, and 80 to 85% of the lung cancer patients, they are NSCLC, and 15% they are small cell lung cancer. EGFR is the most common encountered mutation here. And all over the world, you can see that EGFR mutation has been identified. It has been more present in the Asian population as compared to the Western population or the whites. Like in North America, the incidence is around 22%. In the Europe, it is around 12%, while in Asia, it is between 35 to 40%. So there is marked geographical variation in EGFR mutation prevalence, ranging from 15% in the Europe to 62% in Asia. So patients with lung cancer, they have highest rate of identified brain metastasis, and such incidences are more pronounced in EGFR mutant NSCLC. At final follow-up, 44% of the patient with EGFR mutation tumor, they had brain metastasis, compared to 22% patient with wild type EGFR. And leptomeningeal disease has a poor prognosis and not treated. Survival is around 4 to 6 weeks. Leptomeningeal metastasis may be more frequent in the patient with EGFR mutant NSCLC as compared to the wild type EGFR mutation. So approximately 10 to 15% of the NSCLC patients have brain metastasis at presentation, and approximately 40% patients, they will develop brain metastasis during all the course of the illness. So site of the metastasis also
Hello, Dr. Manish sir.
ज्वाइन कर रहे हो
Okay.
Am I audible?
Yes, sir.
Okay, let me share my screen. So, as regards the site of metastasis, it affects the quality of the life, and there is decline in the quality of life in those patients who have brain metastasis. You can see that those who have adrenal metastasis or liver metastasis or contralateral lung metastasis versus those who have brain metastasis, they have a poorer quality of their life. So patient with single brain metastasis experience the greatest decline in the quality of life compared to the metastasis at the other sites. So coming on to the brain metastasis in EGFR advanced NSCLC and TKI, the brain is a sanctuary site for invading metastatic tumor cells as it is protected by the blood-brain barrier. And up to 40% of the patients with non-small cell lung cancer with EGFR mutation will develop brain metastasis. EGFR TKI are also substrates for human brain blood-brain barrier efflux transportation to various degree, and these influences the distribution of the compound in the brain at equilibrium. And hence it becomes imperative that EGFR TKI must have good blood-brain exposure so that they are able to achieve the intracranial efficacy. So this is the osimertinib differentially penetrating into the intact blood-brain barrier in monkey's brain in the preclinical study. And the osimertinib demonstrates the higher mouse brain concentration than the other TKI. As you can see here, as compared to the gefitinib, the osimertinib the plasma concentration at the same plasma concentration of 0.82 micromole per liter. The brain Cmax is 2.78 micromole per liter in osimertinib versus 0.17 in the gefitinib arm. So these study on the animals show that osimertinib has the highest blood-brain barrier penetration of the EGFR TKI studied. So this is on the right hand side is the whole brain radioactivity following administration of the micro doses of radio-labeled EGFR TKI in cynomolgus macaque, and the data collected for the radioactive decay and for EGFR TKI. So the osimertinib causes tumor regression in EGFR mutant brain metastasis in the mouse xenograft model, as you can see here. Osimertinib was homogeneously distributed in all the regions of the brain in the healthy volunteers. This is the PET imaging of the patient who have received osimertinib in the various subjects. These are subjects 1, 2, 3, and 4, where you can see that there is homogeneous distribution of osimertinib in the brain in various healthy volunteers. And this is the osimertinib achieves the brain exposure in the patient with EGFR advanced and SCLC with brain metastasis. Similar studies in the PET scan, PET MRI images of the patient who have received brain osimertinib in the CA lung. So osimertinib binds irreversibly to the clinical.
Hello, Dr. Manish sir, you are not audible.
Am I audible now?
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir.
So this is the FLORA trial which my colleagues have earlier discussed, and the majority of the patients they had metastatic disease, with 35% having visceral metastasis and 21% having CNS metastasis at presentation. And these patients they were randomized to EGFR TKI, which was standard of care, versus osimertinib, and you can see that the primary endpoint was PFS and the secondary endpoint was overall survival. The PFS is around 19 months and overall survival is around 38.6 months. You can see here, while with the comparator EGFR TKI, it is 10.2 months median PFS, while overall survival is 31.8 months. So the PFS is the direct measure of the drug benefit, and in patients with the known or treated CNS metastasis, median PFS was 15.2 months in the osimertinib arm versus 9.6 months in the comparator EGFR TKI arm. Osimertinib had significantly longer overall survival than comparator EGFR TKI. At 24 months, 74% osimertinib versus 59% EGFR TKI, and at 36 months, it was 54% versus 44% they were alive. And this is the FLORA results, CNS analysis. CNS progression event occurred in 6% versus 15% patient receiving osimertinib versus standard of care for all the patients. And FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status at study entry versus EGFR TKI comparator. And you can see here that the CNS full set analysis, median CNS PFS was not reached, while it was 13.9 months in the comparator EGFR TKI. CNS overall response rates were 66% versus 43% in the EGFR TKI. And the intracranial CNS PFS in the full set analysis, full analysis set was not reached versus 13.9 months in the EGFR TKI, and the hazard ratio was 0.48. The median follow-up time was 12.4 months versus 7.0 months. So CNS PFS was statistically significant with osimertinib as compared to the EGFR TKI standard of care. So these are the results from the FLORA study. The CNS progression by blinded independent committee review occurred in 20% versus 39% in the comparator EGFR TKI. So almost twice as number of the patients in the comparator arm, they progressed as compared to the single agent osimertinib in the FLORA trial. So continuing with the FLORA trial results, the progression in CNS was reported in 6% patients as compared to the 16% patient in the first line EGFR TKI, and the in full analysis set, which included patients with or without CNS metastasis trial at entry. You can see that the investigator assessed CNS progression events were observed in 6% of the osimertinib patient versus 16% of the comparator EGFR TKI group. So first line osimertinib may delay the need for subsequent therapy, and 28% versus 9% continue to receive first line trial drug at 36 months. So coming on to some real world evidence of osimertinib in CNS metastasis, this is the rapid intracranial response to osimertinib without radiotherapy in non-small cell lung cancer EGFR mutant T790M mutation patient, 2 case reports. So this is one case. Coming on to the brief case description, the patient had underwent right middle lobe resection of the lung because of the early stage NSCLC 9 years ago. Multiple nodules emerged in the both lung on the CT scan 7 years ago, which were recognized as a recurrence, and they were identified to have EGFR mutation L858R in exon 21. Gefitinib was administered as a first-line chemotherapy, a first-line treatment for 2 years and 11 months after 3 lines of cytotoxic therapy, that is pemetrexed, carboplatin, itagafil, Jaimersil, otracil, and erlotinib The fifth line chemotherapy was administered, which failed in 3.5 months. After 2 months of the vinorelbine administration as a sixth line chemotherapy, the patient complained of unbearable pain in the spine, and the examination detected multiple thoracolumbar bone metastasis. Radiotherapy was conducted severe pain and to prevent the fracture. Bronchoscopy had been conducted and repeat biopsy revealed T790M mutation in exon 20. And as a seventh line treatment, osimertinib 80 milligram per meter, 80 milligram per kg was administered. From the next day of the brain nodule were detected. So you can see that the multiple metastases at brain baseline, complete remission of the brain metastases except for one in the frontal lobe on the left hand side. You can see after 13 days of the osimertinib treatment. And there is shrinkage of the right pulmonary nodule. You can see on the second picture after the osimertinib administration. This is the case 2. Similar 76-year-old male with 22 pack year of smoking history underwent right upper lobe resection because of early stage NSCLC 10 years ago. EGFR exon 19 deletion was present. Multiple bony metastasis occurred 6.5 years ago, and gefitinib was administered as a first line therapy. Then afatinib was tried. After this, the 4 courses of carboplatin plus pemetrexed plus bevacizumab treatment, and while the fourth line therapy with Tegaford, Jamisil, and Otracil was administered, pleural effusion occurred. The thoracocentesis was done, and the repeat mutation was T790M mutation in exon 20 EGFR, and the osimertinib was administered as the fifth line therapy in the PS was this time. And on the day that is day 10 after the administration of osimertinib was started, brain CT scan revealed the remission of the single brain metastasis in the right parietal lobe, which was asymptomatic. On the 14th day, the decrease on the pleural effusion and the shrinkage of the pulmonary nodule were reported in the chest X-ray. And after a month's chest CT scan revealed shrinkage of the multiple lung metastases that had occurred and decrease in the left-sided pleural effusion. His PCOG performance status improved to 1, and there was decreased pleural effusion. You can see here the observation. There is complete remission of the single brain metastasis that was present pre-treatment as compared to the day 10 of the osimertinib. And there is, after 14 days, there is decrease in the pleural effusion, shrinkage of the pulmonary nodule, and the shrinkage of the multiple lung metastasis, and decrease in the left lung pleural effusion after 31 days. This is the third case, complete remission of multiple brain metastasis in patients with EGFR mutant NSCLC with osimertinib without radiotherapy. So this was 76-year-old woman with no history of smoking. Elevated blood carcinoembryogenic antigen levels were there. The CT scan revealed 40 millimeter shadow in the upper lobe of the left lung and multiple bilateral small nodules in the entire lung field. The diagnosis was T4N1 M1C stage 4B adenocarcinoma lung with EGFR mutation exon 19 deletion, and more than 20 multiple brain metastases which were asymptomatic, and the maximum diameter was 12. They were detected on the brain MRI. And the osimertinib 80 milligram was administered as a first line therapy, and the WBRT was deferred because the patient did not wanted radiation therapy as a treatment. And the T4N1C metastasis stage 4B NSCLC, 40 millimeter wide shadows in the upper lobe of the lung, and the multiple small nodules in the lung field. You can see here on the left hand side. And in the brain, multiple asymptomatic brain metastasis lesion with maximum diameter of 12 millimeters were detected at the first diagnosis, and after 5 weeks, the multiple brain metastases have disappeared completely. This is another cohort study, intracranial outcome of the de novo brain metastasis treated with osimertinib alone in patient with newly diagnosed EGFR mutant non-small cell lung cancer. So this was a retrospective A cohort study patient were selected from institutional database, and if they had the diagnosis of EGFR mutation or treated with osimertinib between 2014 to 2022 and received osimertinib as a initial therapy after first brain metastasis diagnosis. They should had at least one intact brain metastasis, not previously treated with systemic or local therapy, that is SBRT or whole brain radiation at osimertinib initiation, and had brain metastasis, brain imaging baseline with MRI before and after the osimertinib initiation. And you can see there is brain baseline pre-osimertinib scans there, and then regression of the disease which was observed in the bilateral post-osimertinib. And these were the observation. There were 36 patients who had median interval from brain metastasis diagnosis to first-line osimertinib initiation of 25 days. In total, 136 previously untreated brain metastases were tracked from baseline, and the overall 105 lesions had complete response, and 31 had partial response from the baseline in the MRI brain. This reflects the best objective response rate of 100%, and 2-year overall survival was 80%. CNS progression at 1 year, 2 year, and 3 year post osimertinib were 21%, 32%, and 41% respectively. And the region has lesion level local failure was approximately 0.7%, 4.7% at 1 and 2 years post osimertinib respectively. So what are the recent guidelines update? Non-small cell lung cancer, we have already seen osimertinib as a first-line preferred agent as compared to the other EGFR TKI. Thank you so much for your question. You can take few questions. So with this session, we are coming to the end of the today's CME. If there are no questions, I would like to thank you all for attending this academic feast. And I would like to thanks Intas, Zydus, Cipla, and AstraZeneca for extending their help in organizing this evening CME. Thank you so much for your patient listening. Good night. Take care. Bye-bye.
Thank you everyone for joining. Good night.